Hello, everyone. A very good evening. So I'm myself, Dr. Rajesh Gubba. I'm the general medicine educator. So as the continuation of the emergency medicine series, previously we have discussed cardiovascular emergency, neurology emergency, pulmonology emergency, and as well as nephrology emergencies as well. So now in the today's session, I'll be discussing the emergencies in the connective tissue disorders. So one important point you have to remember is that so all these connective tissue disorders, majority of them, they're like multi-system disorders. And all of these connective tissue disorders, they are the one where they have gradual in onset. All these disorders, they are gradual in onset. But because they are being like multi-system disorders, whenever there is involvement of the heart or whenever there is involvement of the brain, there can be, or whenever there is involvement of the kidney, the individual can have a sudden cardiac death, okay, or a sudden death. So as such, the connective tissue disorders, they don't present with the emergency situation. That is, the disease onset is not in the form of an emergency. Because it's a multi-system disorder, whenever there is involvement of the heart or whenever there is involvement of the brain and whenever there is involvement of the kidney, the important visual organs, the individual can have the sudden death. Now, let me try to discuss the individual connective tissue disorders like rheumatoid arthritis, ankylosing spondylitis, Behçet syndrome, Rheumatoid syndrome. So these connective tissue disorders, like what is the cause of death and what are the important manifestations in these particular connective tissue disorders. And followed by that, I will discuss the Scleroderma, Sjögren syndrome, Marfan syndrome, giant cell arthritis, Takayasu arthritis. So in all these, I will discuss like what would be the cause for sudden death and how do you manage that and what are the other important manifestations, all that I will discuss, okay? Right. So the first and foremost, the rheumatoid arthritis. Like in case of rheumatoid arthritis, you need to be very much aware of like what is the cause for the death. These patients with rheumatoid arthritis, even though the joint involvement is a very important manifestation, there are many extra-articular manifestations. Out of that, there is involvement of the heart in the form of the ischemic heart disease. So what would be the cause of death in patients with rheumatoid arthritis? That is development of myocardial infarction. Okay, but as such, what is the pathognomic involvement in case of the rheumatoid arthritis? It is the involvement of the small joints, right? So there will be morning stiffness of the small joints like metacarpophalangeal joints, proximal interphalangeal joints, and then metatarsophalangeal joints. These are the small joint involvement and that too morning stiffness, that is pathognomic manifestation in case of rheumatoid arthritis. Large joint involvement will be there, but they are in the later stages and that too, that is rare. Now, what will be the clinical features in the emergency situation? See, what is the cause of death in these patients with rheumatoid arthritis? The cause of death in these patients with rheumatoid arthritis is the ischemic heart disease. So the clinical features in the emergency situation will be in the form of chest pain. So secondary to coronary artery disease, what will be the clinical presentation? That is in the form of the chest pain. Now, what are the other manifestations or other features that you will have in case of rheumatoid arthritis? The most common extra-articular manifestation is the development of the subcutaneous nodules. And these subcutaneous nodules, they are present on the extensor surface of the forearm. And the other features, if you take multi-system involvement, like lung involvement will be there in the form of pleural effusion, pleuritis, then interstitial lung disease, pulmonary nodules. These are the lung involvement. Kidney involvement will be there in the form of lupus nephritis. Neurological involvement can also be there. I'm just trying to correlate with SLE. Okay. The neurological involvement in case of the rheumatoid arthritis will be in the form of nerve entrapment syndrome. That is carpal tunnel syndrome and as well as the tarsal tunnel syndrome. And kidney involvement can be there. And that is in the form of membranous glomerulopathy in case of rheumatoid arthritis. Then what is the investigation of choice and what will be the HLA association in rheumatoid arthritis? The investigation of choice will be anti-CCP, right? And what will be the HLA association in rheumatoid arthritis? That is HLA DR3 and as well as DR4. Now, what is the treatment in the acute conditions in case of rheumatoid arthritis? The treatment in acute conditions will be NSAIDs and as well as steroids, right? And the drug of choice as a disease-modifying anti-rheumatic drug will be methotrexate. But what is the point of discussion in the today's session is about the treatment of the emergency. See, what did we discuss? What would be the cause of death in this individual? That is ischemic heart disease causing the chest pain. Now, how do you treat this particular emergency of ischemic heart disease? It all depends upon whether it is the ST elevation MI, non-ST elevation MI, or is it just only unstable angina. But what is the one which can cause a sudden death secondary to ischemic heart disease is mainly the ST elevation MI. So the treatment in emergency, it is in the form of either percutaneous coronary intervention or you need to do thrombolytic therapy. Okay, but this thrombolytic therapy is not indicated in case of non-ST elevation MI and as well as unstable angina. Thrombolytic therapy should be given only if there is ST elevation MI. But what is the best method of revascularization? That is in the form of percutaneous coronary intervention, where you can achieve 100% revascularization. So a patient with rheumatoid arthritis, if the patient is presenting with severe chest pain, you have to suspect an underlying ischemic heart disease, and that would be the MI. Okay, so that is about rheumatoid arthritis, how it can present in an emergency situation. Then the next important is the ankylosing spondylitis. And some important images in rheumatoid arthritis that you need to know is the deformities within the rheumatoid arthritis, that is swan neck deformity and as well as the Bottom's deformity. So swan neck deformity, the proximal interphalangeal joint, there will be hyperextension and there will be flexion of the distal interphalangeal joints. Whereas Bottom's deformity, it is exactly opposite to that of your swan neck deformity. And other deformities are the ulnar deviation and as well as Z-shaped thumb. So that is about your rheumatoid arthritis, which can present in the form of an emergency, right? As such, it's a gradual onset disease. But if there is ischemic heart disease, the individual can present with the development of myocardial infarction. Then next is the ankylosing spondylitis. So we have discussed your rheumatoid arthritis. Now let me discuss the ankylosing spondylitis. Now you need to know how is this particular ankylosing spondylitis presenting with the an emergency. See, you should know in ankylosing spondylitis, what is the cause of death? The cause of death in patients with ankylosing spondylitis, it is the fracture of rigid osteoporotic spine. Right? The fracture of rigid osteoporotic spine. So that would be the cause of death in patients with the ankylosing spondylitis. But as such, what is pathognomic manifestation in ankylosing spondylitis? There will be involvement of the sacroiliac joint, and because of the involvement of the sacroiliac joint, the individual can have low backache. And the other important structure which is affected in case of ankylosing spondylitis is the involvement of the spine. What will be that spinal involvement? Where there will be inflammation of the spinous ligaments causing the fusion of the vertebra, where you have a fused vertebra in case of ankylosing spondylitis. But what is the clinical features in emergency situation of ankylosing spondylitis? See, what is the cause of death in the individual? That is fracture of rigid osteoporotic spine. Okay. Now, if there is fracture of the rigid osteoporotic spine, what would be the clinical features in an emergency situation is there will be sudden onset, severe pain, right? There will be sudden onset, severe pain within the back or within the spine, or because of the fracture of the rigid osteoporotic spine, there can be compression of the descending tracts or ascending tracts. The individual can also have the focal neurological deficit. The individual can also develop focal neurological deficit. Now, what are the other features in case of ankylosing spondylitis? The ophthalmic involvement will be there in the form of anterior uveitis. Cardiac involvement will be there in the form of the aortic regurgitation, right? And GIT involvement can be there in the form of the inflammatory bowel disease. So these are the other features that you will see in case of ankylosing spondylitis. And what is the investigation of choice and the HLA association? In case of ankylosing spondylitis, the HLA will be the HLA B27. And you need to know what is a marker which will assess the disease severity in ankylosing spondylitis. In ankylosing spondylitis, the marker which will assess the disease severity will be, that is serum matrix metalloproteinase. Okay, so that is a marker which will assess the disease severity in case of ankylosing spondylitis. Then how do you treat these patients with ankylosing spondylitis? The drug of choice will be non-steroidal anti-inflammatory drugs. And if the patient is refractory to non-steroidal anti-inflammatory drugs, then you need to give TNF-alpha inhibitors. And if the individual is not responding to TNF alpha inhibitors also, then we have the new group of drugs, that is interleukin 17A inhibitors. And these interleukin 17A inhibitors, they are like secukinumab. These are the new drugs which are given in the treatment of ankylosing spondylitis. Now the question is, how do you treat in the emergency situation? See, what is the cause of death in patients with ankylosing spondylitis? That is fracture of rigid osteoporotic spine. So immobilization is very, very important. Right? Immobilization in the individual in the emergency department is very, very important. And followed by that, the spine surgeon, depending upon the severity of the fracture, depending upon the site of the fracture, he will just decide the reconstructive surgery of the spine. So that is about your ankylosing spondylitis, how it can present as a connective tissue disorder emergency. So ankylosing spondylitis, as such, it's a gradual onset disease. That is where there is involvement of sacroiliac joint and as well as spine involvement. An extra-articular manifestation in the form of anterior uveitis, aortic regurgitation can be there. But how it can present in emergency situation is sudden onset severe pain within the back or focal neurological deficit, that is secondary to fracture of rigid osteoporotic spine. So that is about like ankylosing spondylitis, how it can present in the emergency situation. And the next important, okay, and you need to know some important images in the ankylosing spondylitis. See, there are two important images, right? So one is the development of the bamboo spine, where the vertebrae are completely fused because of the ossification of the spinous ligament. And the next important abnormality within the spine that you need to know is the dagger spine. So what is this particular dagger spine is that? So you can just observe here, that is due to ossification of supraspinous and as well as interspinous ligaments that will give you a classical dagger sign in case of the ankylosing spondylitis. Okay, right. Now, after having discussed about the ankylosing spondylitis as one of the, how it can present in the form of emergency, now let me discuss about the Behçet's. Behçet's, even this also, it is also a disorder which is of gradual in onset. Right? Actually, what is pathognomic manifestation in case of Behçet's? That is recurrent oral ulcers. Right? Recurrent oral ulcers, that will be the pathognomic manifestations. And these are like whenever the oral ulcers develop, they appear almost 2 to 5 in number, and they are very painful, very, very painful. But what is the cause of death in these patients with the Behçet syndrome? See, in patients with Behçet's, that is due to pulmonary artery vasculitis. Right? So secondary to pulmonary artery vasculitis, there can be development of pulmonary artery aneurysms. And whenever this pulmonary artery aneurysm rupture because of pulmonary artery hypertension, the individual can die. Okay, so the cause of death in patients with Behçet's would be pulmonary artery vasculitis. And what would be the clinical features in emergency situation? See, in case of pulmonary artery hypertension, what is the important clinical manifestation? That is in the form of dyspnea. So what I mean to tell you is a patient with Behçet's presenting to you with the severe dyspnea, think of development of underlying pulmonary artery hypertension. Right. Yes, Nitin, I will drop my Telegram channel link. Right. So I will send you this PDF in my Telegram channel. All right. So you can just take this. Now, what will be the other features in case of Behçet's? In Behçet's, not only oral ulcers, there will be also the genital ulcers, right? But in case of genital ulcers, you have scar formation. And other features in case of Behçet's will be in the form of uveitis, that is both anterior and as well as the posterior uveitis, okay? And because of this anterior uveitis, you know, there can be the development of hypophion and there can be even accumulation of pus within the anterior chamber. And other features in case of Behçet's will be in the form of skin manifestations, that is in the form of erythema nodosum in the lower limbs and acneiform eruptions that can be seen within the face. Then the next important thing is in case of the Behçet's, what is the HLA association? The HLA association is the HLA P5 or the HLA P51. That will be the HLA association in case of Behçet's. Then how do you treat these patients with Behçet's? See, the pulmonary artery hypertension, how you will treat, I tell you. But before that, you see the treatment in case of Behçet's as such. What is the important problem? That is development of the ulcers over the oral cavity. So you need to give the steroids. That is topical ulcers over the, topical steroids over the ulcers have to be applied. And the other important drug is even the colchicine. And but what is that we are very much worried about is your pulmonary artery hypertension. So how do you treat this pulmonary artery hypertension is like we need to give pH lowering drugs. right? We have pH lowering drugs, like we have endothelin receptor antagonists, then we have phosphodiesterase inhibitors. So these are the drugs that you need to give whenever there is development of pulmonary arterial hypertension in patients with the Behçet's. But what is the cause of death in Behçet's? That is pulmonary arterial hypertension. So that was about Behçet's. So what I want to tell you, a patient with Behçet's presenting to you with severe onset of dyspnea, think of development of pulmonary arterial hypertension, which is an emergency situation. Okay, right. Now, after having discussed about Behçet's, then coming to the reiters. Okay, right. So if you take the reiters or the reactive arthritis. Yes, Salil Kumar Deshmukh, role of steroids in connective tissue disorders. See, all these connective tissue disorders, they are immune-mediated disorders, right? All of them, majority of them, they are immune-mediated disorders. Now, whenever you are giving steroids, they are like immunosuppressive. So in that way, the steroids are useful in the connective tissue disorders. Okay, right. Yes, Deshmukh, I hope I have answered your question. Right. Now, the next important connective tissue disorder, which can present in the form of emergency, is the Reiter syndrome or the reactive arthritis. Now, what would be the cause of death in case of Reiters or reactive arthritis? See, these patients with Reiters or reactive arthritis, as such, that is also a gradual onset disease, secondary to your infection. But what would be the cause of death is, that is development of the cardiac conduction defects. And what is that cardiac conduction defect? That is third degree AV block. There can be development of complete heart block in Reiters or reactive arthritis. And what is pathognomic manifestation in Reiters? That is arthritis, urethritis, and then conjunctivitis. So this arthritis, urethritis, or conjunctivitis will occur secondary to either sexual transmission or secondary to gastrointestinal infection. Secondary to sexual transmission, that will be your chlamydia. Secondary to gastrointestinal infection, that is your Shigella, Salmonella, right? And what will be the clinical features in the emergency? See, the cause of death in this individual is what? Third degree AV block. So what would be the clinical features in emergency? Either the patient will present in the form of giddiness, or the patient will be having syncopal attack. The patient will be having syncopal attack. Okay, so that will be the clinical features in the emergency situation of the Reiters. And the other features, like I have said you, the triad: arthritis, urethritis, and conjunctivitis. Now, what is the HLA association in Reiters or the reactive arthritis? So that will be the HLA B27. Right, that will be the HLA B27. And how do you treat these patients? So it all depends upon which part of the triad the individual is having. For suppose if the individual is having like arthritis, then you need to give analgesics like the NSAIDs, right? And if suppose if you want to treat the urethritis, then you can give the tetracyclines, right? You can give tetracyclines. And when the individual is having conjunctivitis, you can give the topical steroids, right? Topical steroids. Then now the question is, how do you treat in the emergency situation? See, what is the cause of the emergency in case of Reiters? That is cardiac conduction defect, that is third degree AV block, which is nothing but complete heart block. So in the emergency situation, like what you need to do is you need to insert a temporary pacemaker. That is how you can treat this Reiters. Okay. So now to summarize, how can a Reiters can present in the form of emergency? That is by your complete heart block, right? And the treatment in emergency situation will be temporary pacemaker insertion. Right. So these are the 4 important connective tissue disorders, like how they can present in the form of emergency we have discussed. And now, okay, now let us discuss the another set of connective tissue disorders, how they can present in the form of the emergency. So like the SLE, that is systemic lupus erythematosus. Systemic lupus erythematosus, like it is also a multi-system disorder. It is also a multi-system disorder. But what is the most common presentation in SLE is excessive fatigability. They can have fever. They can also have arthralgia. Followed by this fatigue, fever, and arthralgia, the other features are hematological and cutaneous manifestations will be there. But what is the cause of death in patients with SLE? That will be your cardiovascular involvement, right? And what is the cardiovascular involvement in patients with SLE? The cardiovascular involvement in patients with SLE will be in the form of pancarditis. All the 3 layers, pericarditis, myocarditis, and endocarditis, all the 3 layers will get affected. And among these 3 layers, which is the most common one manifestation, that will be pericarditis. Pericarditis, it will present with pointed chest pain, but that will not cause the death. But what would be the cause of death of cardiovascular involvement is the myocardial involvement. See, because of the myocardial involvement, the patient can have the development of congestive cardiac failure, causing acute pulmonary edema, where the individual will have acute onset dyspnea. Then, what is the pathognomic manifestation in SLE? Already I have taught you the patient will present with the most common manifestation will be excessive fatigue, fever, and as well as arthralgia. Next is the characteristic rash over the face, that is malar rash. And they also have discoid rash. And they also, like whenever they are exposed to the sun, they have like photosensitivity. And even you can have the presence of oral ulcers. And joint involvement will be there, that is non-erosive arthritis, right? And cardiovascular involvement, just now we have discussed, that is pancarditis. That is pericardial involvement will be pericarditis, myocardial involvement will be in the form of congestive heart failure, and endocardial involvement will be in the form of Liebman-Sachs endocarditis, where they require the valvuloplasty. Lung involvement will be there in the form of pleural effusion as well as pleuritis, right? And the rare manifestation of respiratory system in the SLE will be shrinking lung syndrome, and that is due to diaphragmatic myopathy. Kidney involvement also can be there in SLE, and that is in the form of the lupus nephritis. Okay, and CNS involvement can be there in case of SLE, that is in the form of psychosis and as well as the seizures. And even hematological manifestation can be there in SLE, that is in the form of pancytopenia, right? So these are the other features, right? Multi-system involvement. But what is the clinical feature in emergency? The clinical features in emergency situation of the SLE will be sudden onset dyspnea. And why is that? That is because of development of the congestive cardiac failure. Now, the investigation of choice and as well as the HLA association. Now, what is the HLA association for SLE is? The HLA association for SLE will be HLA-DRB1, right? HLA-DRB1. This is for SLE. And you should know what is the investigation of choice. So the antibody which is having the highest specificity will be anti-Smith, right? And then followed by that, you have anti-dsDNA, which will tell you about the severity of the disease. But which is the antibody which is having high sensitivity will be anti-nuclear antibody. And how do you treat these patients? You need to give steroids. But how do you treat that acute pulmonary edema? And here you need to give diuretics, that will be furosemide. Okay, so this is about your SLE. So what I want to tell you is a patient with SLE presenting to you with acute onset dyspnea. What is that you need to suspect? Development of congestive cardiac failure, which can cause death of the individual if it is not being appropriately treated. So that is about your systemic lupus erythematosus. So in all the forms of your SLE, we give steroids, but you take endocarditis, that is Liebman-Sachs endocarditis, like you need to give or you need to do valvuloplasty. And another important is like psychosis. There can be development of psychosis in SLE for which you need to give haloperidol. Right, for remaining all the majority of the manifestations, we give corticosteroids. Okay, so that is about your SLE. Right. Yes, Nigda Tripathi. Yes, in a patient with SLE, definitely it is very much required to take a low dose steroids for a prolonged period of time. Right, it is because your SLE, it is a disease where you don't have remission. Right, where you don't have any particular remissions and relapses. Okay, so lifelong or for a long-term period, they require a low-dose steroids, definitely. Okay, right. So that was about your SLE, how it can present in the form of emergency situation, that is in the form of cardiac failure. Okay, right. Now let me discuss the Sjögren syndrome, how it can present in the form of emergency. So if you take this particular Sjögren's, right? So this is the malar rash in case of the SLE, and this is the discoid rash in patients with the SLE. Then followed by that, these are the ulcers in patients with SLE. And the type of arthritis will be non-erosive arthritis in patients with the SLE. Then followed by that, I was telling you about the shrinking lung syndrome. And why is that due to? That is due to, you know, diaphragmatic myopathy, where there will be elevation of the diaphragm and that will compress the lung, and that will result in what is called the shrinking lung syndrome. Now let me discuss. So we are done with the SLE, how it can present in the form of emergency. Now, let me discuss the Sjögren syndrome, how it can present in the form of emergency. As such, Sjögren's is a disorder which is of gradual in onset. Actually, what are the pathognomic manifestations in Sjögren's? The pathognomic manifestations in Sjögren's will be dry eyes, and there will be also dry mouth. right? Dry eyes and as well as dry mouth. That is a pathognomic manifestations. But what would be the cause of death in patients with Sjögren's? These patients with Sjögren's, they are at increased risk of thromboembolism, and there can be development of the coronary artery disease. And that would be the cause of death in patients with Sjögren's. And what would be the clinical features in the emergency situation? That is chest pain. And why is that? That is secondary to the development of myocardial infarction. Now, what are the other features in case of Sjögren's? The other features in Sjögren's that you need to know is there will be also the extraglandular manifestations. Now, if the question is asked, like, what is the most common extraglandular manifestation in Sjögren's? That will be arthritis. Arthritis is the most common extraglandular manifestation. And followed by that, what are the other extraglandular manifestations? That is in the form of Raynaud's phenomenon, renal tubular acidosis, vasculitis, lymphoma. There can be also lung involvement, and there will be also kidney involvement, and even liver involvement will be there, splenomegaly will be there, and there will be also peripheral neuropathy. Okay. Then how do you investigate these patients with Sjögren's? Like, what is the investigation of choice in case of Sjögren's? The investigation of choice in Sjögren's is the antibody, that is anti-Rho and as well as the anti-La. Okay, anti-Rho and anti-La, these are the antibodies which will tell that the individual had developed the Sjögren's. And how do you treat these particular Sjögren's in the emergency situation? In the emergency situation, what is the cause of death? Coronary artery disease. So either you need to do percutaneous coronary intervention or you need to do a thrombolytic therapy. So that is about your Sjögren's, how it can present in the form of emergency. So how it can present in the form of emergency? That is because of development of coronary artery disease. Okay, right. So now, after having discussed about the Sjögren's, which is actually a gradual onset disease, but in long term, the cause of death will be coronary artery disease. That is how it can present in the emergency department. Now, then followed by that, the Gouty arthritis. Even Gouty arthritis, it is the more or less the same. What would be the cause of death? It is the same, that is cardiovascular death. Okay, that is also a cardiovascular death. So now let me discuss about the, so let me discuss about the gout or the Gouty arthritis. So what is the cause of death in these individuals? That is cardiovascular involvement or cardiovascular death. So what will be that cardiovascular death? And that particular cardiovascular death, it is either in the form of myocardial infarction or congestive heart failure. But what is the pathognomic manifestation in Gouty arthritis? The pathognomic manifestation is the involvement of first metatarsophalangeal joint involvement, where there will be swelling of the joint and where there will be very severe pain within the first metatarsophalangeal joint. Now the point is the clinical features in emergency. If the patient develops MI, the individual will have chest pain. If the patient develops congestive heart failure, the individual will have the dyspnea. Okay. Then what are the other features that you will have in patients with your gout or Gouty arthritis? The important manifestation is first metatarsophalangeal joint involvement. And the other important feature is renal involvement. Okay, there can be urate stones within the kidney. So renal involvement is also there in patients with the gout or Gouty arthritis. Then what is the investigation of choice in patients with your gout or Gouty arthritis? That is the synovial fluid analysis. So what will the synovial fluid analysis show? The synovial fluid analysis will show you the presence of negatively birefringent, right? Negatively birefringent, needle-shaped monosodium urate crystals under the microscopy. Okay, so this will be, yes. So you see this? So these are, right. So these are needle-shaped, negatively birefringent monosodium urate crystals. Okay, so that will be the investigation of choice in patients with your gout or Gouty arthritis. Then how do you treat these patients? See, treatment in case of emergency situation is that if the individual is developing coronary artery disease, then you need to do percutaneous coronary intervention or thrombolytic therapy has to be given. But as such in Gouty arthritis, like the treatment will be the different in acute cases and treatment will be different in chronic cases. So you take in case of the acute cases, the treatment will be your NSAIDs, that will be the preferable drugs. Not responding, then we can give steroids. Then followed by that, we give colchicine. Right, we give colchicine. Okay, but what are the drugs which are like, which will reduce the uric acid levels? That means they should be uric acid synthesis inhibitors or they are uricosuric agents. So what are those drugs which are the uric acid synthesis inhibitors? That includes the allopurinol, right? That includes the allopurinol, and the other drug will be febuxostat. Okay, so that will be the treatment. And if you want to give uricosuric agents, that uricosuric agents, they include like probenecid, then benzbromarone, then sulfenpyrazone. These are uricosuric agents. So that is about your gout or gouty arthritis. So gout or gouty arthritis, how it can present in the form of emergency, that is because of cardiovascular involvement, a rare manifestation, and that is in the form of myocardial infarction. Okay, as such, gouty arthritis, the pathognomic manifestation is first MTP, being swollen, red, and very painful. Then, after having discussed about your gout or gouty arthritis, how it can present in the form of emergency, now let me discuss about the Marfan syndrome, how it can present in the form of emergency. So, like if you take this Marfan's, okay, this is another very important image that you have to remember in the gout or gouty arthritis. See, joint involvement, that is first MTP gets affected. If the question is asked, what is the earliest imaging finding in the gout? The earliest imaging finding in the gout will be in the form of the joint effusion. That will be the earliest imaging finding. And what is a typical appearance? These are called as the punched out lesions, right? These are the punched out erosions. And these punched out erosions with sclerotic margins, with overhanging edges, and these are called as the rat bite lesions. Right, these are called as rat bite lesions or the rat bite erosions. Okay, so that is a plain radiograph picture in case of your gout or gouty arthritis. Right. Now, the next is the Marfan syndrome. Right, the next is the Marfan syndrome. Now, the question is how the Marfans can present in the form of the sudden death. The cause of death in case of Marfans will be the aortic dissection. Right, aortic dissection, right? And other important emergency situation that you can have in Marfans is development of pneumothorax. Right, development of the pneumothorax. Okay, and what are the pathognomic manifestations in Marfans? The pathognomic manifestations is that they will be having like a very tall stature, right? And what are the other features that you can have in Marfans? That can be in the form of the ectopia lentis, right? And the palate, if you see the high arched palate, they will be having arachnodactyly, right? And they will have thumb sign and as well as the wrist sign. And the pulmonary manifestations can be in the form of pneumothorax, and cardiovascular manifestations can be in the form of aortic dissection causing the aortic rupture, or even there can be aortic regurgitation as well. And we have a name of the criteria. So in emergency situation, like what will be the presentation in Marfans? They will have very severe chest pain, right? A tearing type of pain, and that is because of the aortic dissection. Okay, and this particular pain from the middle of the chest, it will be radiating even to the back between the two scapular blades. And in case of pneumothorax, what will be the presentation? That can be in the form of sudden onset dyspnea, right? If it is aortic dissection, chest pain. If it is like pneumothorax, sudden onset dyspnea. And the name of the criteria is very, very important. The name of the criteria is the Gens criteria that we follow for your Marfans. Then what is the investigation of choice? Marfans is due to what? It is due to gene mutation. And what is that particular gene mutation? That is fibrillin gene mutation. So the genetic analysis will be showing FBN1 gene mutation. That will be the investigation of choice. But how do you treat this in the emergency situation for the Marfans? If the individual has developed aortic dissection, you need to see that the heart rate is maintained around 60 to 70 per minute, and blood pressure is reduced. Systolic blood pressure is reduced between 100 to 120 millimeters of mercury. So in the emergency situation of aortic dissection, you need to give labetalol, right? You need to give labetalol. And further, you need to plan the stenting or grafting, right? Stenting or grafting is being planned depending upon where exactly is the site of dissection and what is the extent of the dissection. So that is about your mark. And if it is like pneumothorax, what you should do, like if it is like in the form of tension pneumothorax, you need to take a wide bore needle and puncture the pleura in the second intercostal space in the mid-clavicular line, where there will be release of pressure. And subsequently, you need to place a tube within the fifth intercostal space in the mid-axillary line, depending upon whichever side the pneumothorax has developed. So that is about your Marfan's, how it can present in the form of an emergency situation. So Marfan's, which is a connective tissue disorder, as such, it's a gradual onset disorder. But how it can present in the emergency department, that is either in the form of aortic dissection or in the form of pneumothorax. Okay, so that is about your SLE, Sjögren's, Gouty arthritis, and Marfan's, how they can present in the form of the emergency situation. Next, the other disorders that we have, yes, right, these are the last set of disorders, like how they can present in the form of emergency situation. You take the scleroderma, right? Scleroderma is where there is excessive accumulation of collagen within the skin and the internal organs, resulting in the sclerosis. Now, what would be the cause of death in case of scleroderma? The cause of death in scleroderma, it is due to development of the pulmonary hypertension. But as such, scleroderma, is it an emergency disorder? No, it's a gradual onset disorder. And what will be the important involvement is the skin involvement. And even though that skin involvement will be, and rather, it will progress to the remaining parts of the body as well, right? See, we have two forms of scleroderma. One is the localized scleroderma, right? One is the localized scleroderma, and the other one is diffuse scleroderma. So you take localized scleroderma. Localized scleroderma, you need to remember about that crest syndrome. Crest syndrome is what? Where there will be calcinosis, Raynaud's phenomenon, esophageal dysmotility, sclerodactyly, and then telangiectasia. So this is what is your crest syndrome that you will have in case of the localized scleroderma. But whereas you take diffuse scleroderma, in diffuse scleroderma, apart from this widespread skin involvement, there will be diffuse or rapid visceral organ involvement will be there. Rapid visceral organ involvement, like GAT manifestations can be in the form of like dysphagia, pneumatosis intestinalis, musculoskeletal involvement can be in the form of symmetrical arthritis, kidney involvement can be in the form of like renal artery stenosis, lung involvement can be in the form of interstitial lung disease, cardiac involvement can be in the form of pericarditis and pericardial effusion, and pulmonary involvement can be in the form of like pulmonary hypertension. Okay, and because of the kidney involvement, they can also have malignant hypertension, which is nothing but your scleroderma renal crisis. Okay, so that will be the other features. Now, what you have to remember is the investigation of choice. See, in investigation of choice is what it is mainly the antibodies. So if it is like localized scleroderma, the antibody will be the anti-centromere antibody. And if it is diffuse scleroderma, the antibody will be anti-topoisomerase antibody or your anti-SCL70. And how do you treat this? You need to give steroids. Scleroderma. But how do you treat this pulmonary artery hypertension? See, how does this pulmonary artery hypertension will present in the form of, this will present in the form of a very severe onset dyspnea. So for which you need to give the pH lowering drugs, right? For which you need to give pH lowering drugs, okay? And see, I was discussing even your Behçet's. Behçet's also, the cause of death will be pulmonary artery hypertension, that is pulmonary artery vasculitis, in which you need to give pulmonary artery pH lowering drugs. So what are these pH lowering drugs? Like we have, I'll just give you the table. This is very, very important, right? So we have prostanoids, but these are like parenteral route, not the oral route. Like epoprostenol intravenous route, treprostinil, it can be given through three routes: intravenous, subcutaneous, and inhaled. And iloprost, I for inhaled route. The other, so these are all what pH lowering drugs. The other ones are the endothelin receptor antagonists like bosentan, ambrisentan, and as well as sitaxantan. And then we have phosphodiesterase inhibitors like sildenafil, tadalafil, and as well as vardenafil. So these are the pH lowering drugs. Okay, so that can be given in the emergency situation or whenever there is development of pulmonary arterial hypertension in patients with the scleroderma. Okay, so scleroderma as such, it's a disorder which is of gradual in onset, but how it can present in the emergency department, that is because of development of severe pulmonary artery hypertension causing severe onset dyspnea. Okay, so that is about like scleroderma, how it can present in the emergency department. Okay, next. The next important connective tissue disorder which can present in the emergency department is the APLA syndrome. Actually, APLA, it is a form of connective tissue and as well as it is a hypercoagulable disorder also. But what would be the cause of death in case of the Apla syndrome? So we are done with the scleroderma. Now you take the Apla syndrome. So what would be the cause of death in case of the Apla syndrome? See, because of its hypercoagulable nature, there can be thrombus formation in the coronary arteries, causing coronary artery death. And they can also cause even cerebrovascular accidents. But cerebrovascular accident will not cause the death. There will be focal neurological deficit. But the cause of death would be because of the thrombus or thromboembolism within the coronary arteries. And like, what will be the pathognomic manifestations in Apla syndrome? The pathognomic manifestations in the Apla syndrome will be recurrent abortions if the patient is female. Right, if the patient is female. Okay, right. Deshmukh, multiple sclerosis, it is like a neurological disorder, right? And regarding multiple sclerosis, how it can cause emergency, I have discussed that in the neurology emergencies, right? We are discussing connective tissue disorder emergencies. So multiple sclerosis, I have discussed that in the neurology. Okay, Deshmukh? Right. Then what would be the clinical features in the emergency situation? See, the clinical features, the patient can present with severe chest pain. That is because of coronary artery disease. The patient can be present in the form of the focal neurological deficit. And why is that? That is because of the cerebrovascular accident. And if it is like an abortion, right? So the patient can present with bleeding per vaginum. Okay, so that will be the clinical features in the emergency department. And the other features is that this particular hypercoagulable disorder, the thrombus, which can rupture and where the emboli can enter into the different parts of the circulation all over the body. Now the question is the investigation of choice, right? So the investigation of choice in case of Apla syndrome will be anti-cardiolipin antibody. Mainly the antibodies are very important. Anti-cardiolipin antibody, then anti-beta-2 glycoprotein 1, and the other important antibody is lupus anticoagulant. So these are the three antibodies which are very important in case of Apla syndrome, by which we will be able to diagnose the Apla. So how do you treat these patients with the Apla syndrome? Basically, it's a hypercoagulable disorder. So how do you want to treat this? You need to give the anticoagulants and then the antiplatelets, that is aspirin, we give. So, and if it is coronary artery disease causing Apla syndrome, then you need to do percutaneous coronary intervention or the thrombolytic therapy should be given for the revascularization. So that is about your Apla syndrome, how it can present to the emergency department. That is in the form of coronary artery disease or in the form of focal neurological deficit secondary to cerebrovascular accident. Okay, right. Yes, Rizwana, PDF milega aapko. I will send the PDF on in my Telegram channel, right? That is Dr. Rajesh, Medicine Made Easy by Dr. Rajesh Gubba. So there you can get the PDF. Okay, right. So now after having discussed about this Apla syndrome, which can present in the form of an emergency situation, now let me discuss about the vasculitis. We have some vasculitis which can present in the form of death, like giant cell arthritis and as well as Takayasu arthritis. See, giant cell arthritis and Takayasu arthritis, both of them, they are the large vessel vasculitis. But the only difference is what? Your giant cell arthritis is the one which will be presenting after 50 years, and your Takayasu, it is present, the presentation will be less than 50 years. That is the only difference. Now, in case of your vasculitis, what would be the cause of death? The cause of death in both of them, it is the development of the coronary artery disease. But what is the pathognomic manifestations? If you see, in giant cell arthritis, the pathognomic manifestation will be in the form of headache. And where exactly this particular headache will be? Mainly over the temporal area. Right? That is because of the inflammation of the temporal artery. That is because of the inflammation of the temporal artery. Okay. And that would be the pathognomic manifestation. And what would be the clinical features in the emergency situation? That is in the form of MI, where there will be very severe chest pain. That is because of your coronary artery involvement or because of the left main coronary artery being involved. What are the other features in case of your giant cell arthritis is the eye involvement. So what is that ophthalmic involvement within the giant cell arthritis? That is in the form of the because of ophthalmic artery involvement, the individual can have sudden onset blindness. right? The individual can have sudden onset blindness. Visual loss is the most feared complication. And that particular visual loss is caused by the occlusion of posterior ciliary branch of the ophthalmic artery. Posterior ciliary branch of the ophthalmic artery. And how can you assess the risk of blindness? By assessment of an inflammatory mediator, that is interleukin 6. The interleukin 6 levels will correlate with the blindness. And then what is the investigation of choice here? The investigation of choice is you need to do biopsy of the temporal artery where you will be finding the presence of the granulomatous inflammation. And other important feature apart from blindness is polymyalgia rheumatica. Polymyalgia rheumatica is that where there will be stiffness of the shoulder girdle and as well as the hip girdle, right? And how do you treat these patients with giant cell arthritis? Like we need to give steroids. There is no doubt in that, right? And in emergency situation, right? What is the cause of death? Coronary artery disease. So percutaneous coronary intervention or thrombolytic therapy should be given. So that is about your giant cell arthritis, how it can present to the emergency department. And you take Takayasu arthritis. That is also a form of large vessel vasculitis. See, this particular Takayasu arthritis, right? This particular Takayasu arthritis, this can also present with coronary artery disease. But what you have to remember, one important point is that this vasculitis causing coronary artery disease, the site of lesions will be the ostial lesions, right? What do you mean by the word ostia? Exactly at the origin, you have the inflammation of the vessel causing ostial stenosis, resulting in coronary artery disease. So there can be ostial left main coronary artery stenosis. There can be ostial left circumflex artery involvement. There can be ostial LAD. There can be ostial right coronary artery involvement. Then next is the pathognomic manifestations. What is pathognomic manifestations in patients with your Takayasu? The pathognomic manifestations in case of Takayasu is like pulseless disease. Okay, because what is the most common vessel which is affected in Takayasu? The most common vessel which is affected in Takayasu is the subclavian artery. So because of the inflammation of the subclavian artery, the blood supply to the upper limbs can be reduced, resulting in pulseless disease, where there will be unequal blood pressure in both the upper limbs. That is a characteristic feature that you can see in case of Takayasu arthritis. And what will be the clinical feature in emergency? That is in the form of the myocardial infarction, right? That is in the form of myocardial infarction. Okay. Then what are the other features? The other features, the other vessel involvement can be there in Takayasu. Not only subclavian artery, there can be involvement of celiac trunk causing visceral ischemia. There can be renal artery involvement. There can be vertebral artery involvement. There can be spinal artery involvement. So all other large vessels can get affected in case of the Takayasu. Then what is the investigation of choice in Takayasu arthritis? The investigation of choice in Takayasu arthritis is the MRI of the aorta. And how do you treat is you need to give the steroids. But if the individual has developed coronary artery disease, then you need to do percutaneous coronary intervention, then followed by that thrombolytic therapy should be given, right? Then thrombolytic therapy should be given. And whenever you are giving this thrombolytics, see, there's one important question regarding this thrombolytic therapies. So which are the various thrombolytic agents we have? Like we have tenecteplase, then retiplase, altiplase, then streptokinase. But among all these, which is the best thrombolytic agent? That will be tenecteplase. Please remember, that will be the tenecteplase. Okay. So this is about your Takayasu. So how Takayasu can present in the emergency department? That is in the form of coronary artery disease. That is in the form of MI. Okay. So that is about your all the connective tissue disorders, how they can present with the emergency. So let me just quickly summarize. You take rheumatoid arthritis. What is the cause of death? Ischemic heart disease. Ankylosing spondylitis. What is cause of death? Fractured rigid osteoporotic spine. Behçet syndrome. What is the cause of death? Pulmonary arterial hypertension. Rheumatoid syndrome. What is the cause of death or emergency situation? Cardiac conduction defects that is causing complete heart block. Then systemic lupus erythematosus. Like what is the cause of death? The cause of death in case of systemic lupus erythematosus will be cardiac involvement, that is congestive cardiac failure presenting with acute heart failure. Okay, right. And Sjögren syndrome. What is the cause of death? Coronary artery disease, thromboembolism. Gouty arthritis, cardiovascular death. Marfan syndrome, what is the cause of death or what would be the emergency? That is aortic dissection or pneumothorax. Okay. Then you take scleroderma. What would be the cause of death in case of scleroderma? That is development of the pulmonary hypertension, right? And then followed by that Apla syndrome. What would be the cause of death? Coronary artery disease. And even giant cell arteritis and Takayasu, the cause of death will be the coronary artery disease. Okay. So this is what you need to know, like how the connective tissue disorders, they can present to the casualty or in the emergency department. Okay. So with this, I'll wind up this particular session of the connective tissue disorders, how they can present in the form of emergency, right? So the PDF will be available for you in my Telegram channel, that is Medicine Made Easy by Dr. Rajesh Gubba. Thank you very much. See you again in the next upcoming sessions with these emergencies.